Some of the early adopters, used IBM Watson. That was the first big application of this. And it's very cost prohibitive. Most organizations couldn't afford to do it. Implementation success was not based on the size of the organization, but based on the leadership and the vision. One of the first hospitals was Mass General. They were the ones that started using Watson in their analytic systems. And I read that Johns Hopkins was doing it, but I was having dinner with the CIO at Johns Hopkins the other night, and he says, no, we're not doing that anymore. So what has changed? Well, ChatGPT, you know what I'm talking about. And all the other competitors out there now, like OpenAI and stuff like that, are out there, so it brought the prices down. And the other thing that makes it easier is now most of the hospital systems have their own EHR in place. That was being impediment before, because if you don't have digital data, you can't do much with it, in the AI realm. So, utopia. This is what we're all trying to get to one day. So, if you have electronic health records, you have your clinical data, you have some demographic data. EHR and artificial intelligence, you have your clinical data, more demographic data. You can also have your lifestyle, environmental data, genomic and research data access. So you look at the clinical data, you got your medical diagnoses, your demographics, your test results, and so forth. So you can figure out, okay, this is what the picture of the person looks like from the clinical slide. Demographic data, typical stuff, your family, your gender, your age, ethnicity, so forth, your weight, so on. Then we start getting into what we call the social determinants of health. These are the things that are very predictive. They've been found to be very predictive of whether someone's going to have better outcomes or not. So, like, in terms of a caregiver, if you have somebody in your house or somebody close to you who's going to make sure you take your medicine, make sure you take your follow-up appointments and so forth, you're going to have better outcomes than those who don't. Same thing with the mobility. If you're bedridden or you sit around a lot, your outcomes are not going to be as good as someone who's up and being active. In the education level, the more educated people are, the better outcomes they get out of their medicine. Access to private transportation. Someone's going to drive you to your appointment, either you or someone else. You get that. Then there's environmental data. That's the area income level, which is very probably highly correlated to education level, right? Think about that. And you have access to public transportation. You're in Chicago, you have good public transportation system. Out in California, where I live, you don't. My son's commuting while he's in school to his evening internship. Took him 2 hours back and forth. Okay, on buses. No fun. So, but Cleveland Clinic was one of the first hospital systems to pioneer using ride shares. They contract with Uber, and CMS has approved reimbursements for that kind of stuff now, so that's helpful too. Then you have access to grocery stores. We can call them, if you live in a food desert, okay, what they call it, then you're not going to have as good an outcome as somebody who has access to a grocery store. You get fresh fruits and vegetables and other foods, because you're going to tend to eat what's close to you, which would mostly be McDonald's or whatever like that. Even if you have public transportation, can you imagine lugging 5 bags of groceries on a CTA bus? That's not going to be a lot of fun, is it? Okay, you're in a CTA bus sometimes, it's not fun, period. I did it when I was here, so that's cool. Then there's the genomic data. Your DNA sequencing, your genetic markers. I have a friend of mine in Florida right now, and she thought her father passed away last year of a rare disease. And so his doctor suggested she get tested for the same disease and found that she has the same markers. Her brother and sister don't have them, but she has it. So they're trying to be preemptive and trying to treat that ahead of time as best as they can. So it's very important to have that. Then there's research data, you know, living in San Diego is a very biotech-friendly area. We have a lot of new biotech companies are out there. And so I was in a venture capital and biotech conference 2 weeks ago, talking about the clinical trials that they're doing, trying to take the new products to market. You know, do trials for it and see how well it's doing in the trials versus the population. And all that is research studies. You know, as a doctor, you can't read all those research papers. You can't read all those journals. You know, every specialty has their own journal, and at least sometimes they have 2 or 3 of them. And there's no way the doctor can keep up with it. You know, I've had a friend who had high blood pressure, and she went to the doctor, and the doctor prescribed one medicine for it. She wasn't doing too well on it, so she called, making an appointment to see another doctor. He was on vacation, so she saw his colleague, and he prescribed something different for her, but she didn't do even worse on that medication. Went back to see her doctor when he came back from his vacation. He says, you know what? I bet you're feeling sluggish and this and that and so forth and so forth. I said, yeah, I am. But that medication he prescribed for you does not do well with African American people. Okay? And he just happened to know that because he reads a lot. Not every doctor is like that. There's just too much stuff to try to keep in mind. So what we're trying to do is get to the right information, to the right, at the right time, to the right provider, to get the right treatment plan and diagnosis. Okay? That's the bottom line. So the challenges we have right now in healthcare, there are many of them. You know, from healthcare, healthcare technology burnout, you got people issues, good processes, technology leadership, and financial right now too. So you imagine yourself being a healthcare executive, and you have, taking care of your daily hospital operations. Then on top of that, the last year you've done the electronic records. Then you have the ICD-10, and you implement that. And now you're trying to do public health and ICD-10, and now you're trying to do artificial intelligence. What happens there? Okay.